Great. Hi, everyone. Welcome to House Care. It's Wednesday, February 28th. And we are taking up 766 this morning, which is prior authorizations, claims, edits, and some other stuff. So we have a new draft, but as happens around here is our legislative council has to be in another committee for a little bit. They're hearing amendments on S18, which is on the floor today. So we're going to go ahead and start with some testimony, see how far we get before we would need to actually review the draft to hear the rest of the testimony. We had a lot of people, we had people send in written testimony, which I sent to everyone last night and which has been posted. And then I also sent the draft and it's posted of the new draft that Jen will walk us through. So I think we're going to start with health first. You want to come up? That would be great. Welcome.
Good morning, everyone. Thank you for the opportunity to speak again in support of this bill. I'm Susan Ridson. I'm the executive director of Health First, which is an independent practice association. So we represent 62 specialty care and primary care physician-owned practices across the state. So over the last weeks, as you know, you've heard lots of testimony and information about the administrative burden in practices due to things like claims edit processes that are inefficient, prior authorization, step therapy. I can't overstate the burden this is for practices. It results in delayed care, frustrated providers, and so forth. And I thought I'd just pull up a few of the quotes that some of our community physicians have said about this. Administrative burden is one of the main limitations of our ability to care for patients. That's huge. Our staff is small, and these burdens are directly on physicians and nurses. These aren't, staff removed from the situation. They are clinicians spending their time on this. We spend an increasing amount of time and resources on these issues to the point that our practice is in constant financial peril. This is what happens in the independent practices in particular, because they have such thin margins. The more time we spend fighting for patients, the less financially secure our practices. This one, patients and staff are frustrated by the delays in care, as you know, created by the obstructions of insurers. Patients get angry at the staff, and then the staff gets burned out and quits. Then we have fewer clinicians in practice. We as providers, we haven't talked about this yet, but I think it's really significant. We as providers are no longer in control of our patients, or are no longer in control, and the patients realize that. And they have lost faith in the profession, so that, healing relationship between the provider and patient is starting to break down. And that's a huge loss. And then we have a situation where you've heard many of these, but person was on commonly prescribed medication for years for the blood pressure. For some reason, the medication was denied. He ended up in the ED. And to this day, the physician really has no idea why the medication was denied. So, when the payers talk about the price tag associated with this bill, we believe that they don't factor in the cost of these things. What about the cost of that patient going to the ED? Where is that factored in? The cost of patient worrying and having to go back to the pharmacy multiple times, and their health potentially worsening because of delays in care. What about the cost of wasted time that providers are spending on the phone waiting to talk to insurers and get things cleared up? The cost of submitting prior approvals, where there's a high percentage that are actually approved in the end. It's just wasted time. The cost of frustrated providers and staff who are just quitting, and then practices are closing. The cost of the loss of trust in providers and the health system. And then, we had a claims edit situation that was actually inappropriately driving care to more expensive sites. And that would have never been discovered if the provider, the physician themselves, took the time to find that situation and fight for it. And then, you heard from Dr. Lynn, the cost to her practice. It was months where she was fighting this claims that an inefficient process. So she finally requested, an audit of her records, and it was found that 100% of her cases were appropriate. So all of that is lost cost. So in summary, we appreciate your support, and we again ask for your support with this important piece of legislation. It's going to help standardize and streamline some of this admin burden that is significant, and will help to put the control of healthcare where it belongs, which is with patients and providers and not the system. Thanks again for your work.
Thanks, Susan. I think we have a question, at least one. Art?
Yes, and thank you for all this testimony. I want to understand beyond all the frustration, time wasted, and so forth. If we enact this bill, okay, how will it help save healthcare costs? What will happen in a doctor's office that will save money for the patient who has to come to your doctors? What mechanism takes place? Will there be layoffs of some staff so you're leaner and can not have to do that, or what will happen?
In my mind, every minute that is not spent on admin burden that has no clear benefit, that's more time that the clinician can have to see patients. So, it's more patients, so more accessibility.
Okay, so more patients will be seen,
Yeah.
but the patients that are seen will have the same cost burden, or do you see that lessening somehow? I'm just trying to get at what financial burden will be changed by enacting the bill. That's all.
Well, if you look at it long term,
Yeah.
right, and I understand what you're saying. It's one piece of a larger problem. There's no question. But the more that we can chip away at these things, the better, the less burdens providers will be. They will be less frustrated. They will stay in practice longer. And this really hits the independent practices even more acutely because they have such thin margins.
Yeah.
So when we lose more independent practices, the price of healthcare goes up.
Yeah.
So if we can, decrease some of this burden, it should result in better access and more cost-effective care.
Okay. Thank you.
Yeah.
Any other questions for Susan? Great. Thank you, Susan, for your work. So we have legislative counsel here, so I'm going to turn to Kelly, because you're the only other provider, I think. Did you want to wait till we walk through the new draft, or do you want to provide testimony now?
I can wait in my testimony. I'm here more to answer any questions.
Okay.
We submitted, our memo and kind of response into looking at some of the testimony provided by payers and Blue Cross. So that to me has said, what we need to say, but I'm here really to answer any questions or if there's anything specifically you wanted me to go into further detail on.
Okay. Can you, would you be willing to answer Art's question from the UVM Health Network position?
Yeah, I think Susan did capture it well. I will say the savings is something
Kelly, I'm sorry. Can you, since you're on Zoom especially, can you just say who you are for the record?
I'm sorry. My apologies. Kelly Lang, Vice President of Managed Care Contracting for the UVM Health Network. So in terms of potential savings from this bill or impact on healthcare, I do think we will have the ability to redeploy FTEs, which perhaps means not hire new ones. It's in working with our CFO, we do find alignment if we have the ability, to have alignment, whether on claims edits or prior auths, to automate and therefore reduce the actual manual work. And so I do find we will have savings there. Additionally, less write-offs. So right now, if we get a claim denied, we have to write it off, right? It's bad debt. And so if you look into our budget submission, we have a fair amount of write-offs. And if you look at how we build our budget, we need enough reimbursement from commercial payers because Medicare and Medicaid is capped to cover, write-offs. So therefore it goes to our rate ask. So I can't commit to a hard dollar right now. I do think that's part of the report in terms of what this does impact, that we agreed to, work on in this bill. But I do feel this will allow for fewer write-offs, likely fewer staff in terms of needing this. That staff can be redeployed. As you know, we have a workforce issue. And so we've talked about some of the roles here are clinical and nurses or analysts who can be doing a lot of other great work. And right now, they're submitting medical records. So I do believe this would be reflected in the hospital budgets for UVM Health Network and likely other hospitals.
Thank you. Yeah.
Great, thanks, Kelly.
Yep.
Great, are you good, or you need a couple minutes?
I'm okay, we're doing it's okay, fourth bill so far.
I know, so that's why, we can take a break if you need a couple minutes.
No, we're good.
We're gonna do the walkthrough of 7 new draft.
Yes, I am.
Legislative council was up very early this morning doing. bills.
Morning. Harvey, this is legislative council. There's already got me all set up to
I was
post.
gonna ask who you were. I didn't.
Good thing I introduced myself.
Trying to figure that out.
All right, so we are looking at a new draft of H 766. This is name changes a little bit by the end, but an act relating to prior authorization, step therapy requirements, health insurance claims, and provider contracts, because we get rid of the election or cost sharing amounts language at the end. So do you want me to just highlight the changes from the previous draft?
Does everyone feel okay with that? We know the bill pretty well? Okay, go ahead.
So maybe I'll just name the sections as we go through them. Section 1 is dealing with step therapy. Don't believe there are any changes there. Section 2 has the claims edits language. I think there are a few sort of minor tweaks in here. So one of them was, go back a little bit.
Excuse me,
Yeah.
how will we know where the changes are?
As they're highlighted. Yep, highlighted and bolded is new.
Gotta scroll pretty far in, Topper.
You do. So, all right, so I'm going to back up to set the context here. So this is page 4. This is language we've looked at before, but we're talking about which edit standards apply. And it says, except as provided in subsection C, when editing claims, health plans, contracting entities, covered entities, and payers shall require not more than the following edit standards, processes, and guidelines. And then it talks about these ones for claims for outpatient and professional services, and then what happens for facility claims, and then what happens for any other claim that is not addressed by subdivision 1 or 2. And in that case, it's appropriate nationally recognized standards, guidelines, or conventions approved by the commissioner.
Sorry, we have one question.
Yeah,
before you
just
keep going.
So is there definitions for outpatient and professional services in
Statute.
18 VSR?
No, not that I'm aware of.
No. Okay.
All right, so then we get to, remember the lead-in language was except as otherwise provided in C. So now we're in C. Adherence to those edit standards that are set out in subsection B is not required in certain circumstances. Again, nothing has changed yet. So not required in existing law when necessary to comply with state or federal laws, rules, regulations, or coverage mandates, or for edits that the payer determines are more favorable to providers than those in subsection B, as long as those edit standards are developed with input from relevant provider organizations, clearly supported by nationally recognized standards, guidelines, or conventions. And then we'd had a separate C approved by the Commissioner of Financial Regulation. So that would say that provided the edit standards are approved by the Commissioner of Financial Regulation. DFR asked to combine those. So now it is clearly supported by nationally recognized standards, guidelines, or conventions approved by the Commissioner of Financial Regulation. So all of that was leading to get us to this point, which is it's not that DFR has to approve every single edit standard. It's that they need to approve the nationally recognized standards, guidelines, or conventions that are clearly supporting the edit standards. How we doing?
That makes sense.
Basically approve the whole thing.
No, that they didn't want to approve. So they don't want to be approving at the granular level. They wanted to be approving at the broader
That's
level.
what I
So they're
mean.
approving at the broader level.
Yeah.
Okay.
All right.
And then I just relettered this one to be C, not D. All right. Subsection D of this section, the various payers shall not release their edits more than quarterly to take, should say more often than quarterly, shouldn't it? So, more often than quarterly to take effect on January 1st, April 1st, July 1st, or October 1st, as applicable. And the edit shall not be implemented without, and in the previous draft, it was prior review and approval by DFR. Now, again, we're backing up a little bit, without filing with the Commissioner of Financial Regulation to ensure consistency with the nationally recognized standards, guidelines, and conventions. So having DFR take a little bit less, again, granular role in approving each thing that happens. Just circle yes.
I'm going to ask this question because I know I'm going to be asked it by somebody. Can you explain what conventions means?
So these are nationally recognized conventions, sort of usual ways of doing things.
Not like a convention like you go to.
Not a nationally recognized event. This is a nationally recognized way of doing things. A conventional way of doing things. A conventional practice in a non-event sense. Okay. All right. Let's do your question. Okay. So then we have in E, except as otherwise provided in subdivision 2, health plan payers, I'm going to just abbreviate to payers for explanation purposes. No payer shall subject any healthcare provider to a prepayment coding validation edit review. And I think I had just added that to make it clear that when that's sort of an exception in number 2, nothing in this subsection shall be construed to prohibit targeted prepayment coding validation edit review under certain circumstances. So this, except as otherwise provided in subdivision 2, is not necessarily a change from the prior draft. I just think it's clearer to acknowledge that there's some inherent conflict between those two provisions. All right, moving on.
That all the claims edits.
I believe so, but I'm gonna peek ahead here. Yes, our next change is on page 11.
Okay, so can we just stop for a
Yep.
second on claims edits? I want to talk about the one that I put out to you last night, I think. So in previous testimony with everyone and in conversations with DFR, there was disagreement on the intent of the language in claims edits, where the intent is not to include pharmacy. But the way it's worded, the payers believed it would mean they can't do claims edits for pharmacy. And we want to be clear, that's not what we're trying to do. So I had, Jen did not put it in, but I had sent it to you. Did I send that to you?
Yes, but I'm not sure I understand. I
Okay,
think the language you sent me does what you just said, so I'm gonna want to
Okay.
understand.
so that's what we want to do.
Okay,
So.
the idea is just to carve prescription drugs out of the claims edit
Yes,
stuff generally.
yes. So
I think we want to make clear that prescription drugs are not included in A and B section 2,
Page we are.
page 4. So starting with line 7, 9, and then 11. Essentially, we want to make sure which is kind of why I asked you if there's definitions of things like outpatient or professional services in statute. We want to make sure that prescription drugs are not covered in A and B. They're not included in that. And possibly come up with some language to ensure what we're really talking about in A and B as far as what claims we're talking about. Does that?
So I want to stick with the first part, which is pharmacy. So what I sent you, I think, was excluding, or I forget how we said it. So if you don't
I
think,
think it said it in here for any other claim to include, I think you had to include prescription drugs, then the edit can't require more than other appropriate nationally recognized edit standards.
Okay.
If the point is to not apply any edit standards, then we don't want to say
say it there.
they're an other claim not addressed by 1 and 2. We want to say
Okay,
none of this applies. There's no requirement to follow prescription drug claims can be edited out in ways that are not otherwise allowed in here.
okay.
So I need to think about the best way to say that,
And so we don't need that right now. I just.
and I may want to just,
Yep. Talk to.
check in with some stakeholders to understand the right place and language.
Okay. So that's the first part. And what was your second part?
To clarify, well, this was DFR's feedback regarding just
Yeah,
the definition of medical, and that they would include everything
Oh,
under
that's
that.
right. No, so we're gonna get to that.
Okay,
That's what this
Okay.
pharmacy change.
Okay.
So it's just the pharmacy.
Okay.
We want to make sure pharmacy is not included.
Okay.
Is everyone okay with, this is more conversation for the table. I think if you've been reading some of the feedback, and one of the numbers we got was specific to the cost if we were including pharmacy, and our intent was never to include pharmacy. And so with back and forth and after talking to DFR, to get their understanding of the language, the way they read it was that it could include pharmacy. So we want to take that out. Everyone understand, and are we good with that?
yes.
As far as I know right now, I'm good.
Okay, perfect. So we'll put it in and come back to it.
What I know is here, this is the knowledge.
Okay. Okay, great. Sorry, Jen, for stopping you. but
No,
it
you're
was good to
you're
get it on the
fine. That's
table.
great. I think it makes sense to do it when we are looking at it. All right, so are we ready to move on to section 3?
Yes.
So section 3 is going to be on page 10. Starts on page 10. And this is the part about some of it about prior authorization requirements. We have 2 different sections that amend the same statutes, but sort of far apart. So in this one about prior authorization and reducing variability, et cetera, there was just a provision that was requested, this is on page 11, that a health plan, and that it be clear that the list of services and supplies that require prior authorization have to be available to the public. It can't be behind you have to create an account. So we talked about publicly available, but I thought it was even clearer if we said that the plan shall make the list available to the public on the insurer's website. So public is not just members of the plan, but public. Right? Let me look ahead for our next changes, which I actually don't think come for a while. Next change is a minor change that leads into some bigger ones. So I'm scrolling down now to page 17. So page 17 has the prior authorization. We had some impact reports dealing with specifically with insurance. So, and then we're creating a new section on provider impact reports. So I just renamed this one insurer impact reports to make it clear how it differs from section 8, which would be provider impact reports. So in section 7, the legislature is asking that by January 15th, the bigger insurers report to this committee and the Senate committees about the impact of the prior authorization provisions of this act on certain things during plan years 25 and 26. This new section would, because we don't actually regulate provider organizations, would request that organizations representing Vermont's hospital-employed, federally qualified health center-employed, and independent healthcare providers who are affected by the prior authorization provisions of this act gather information from their members on or before January 1st, 2025, which is when these provisions take effect, or the prior authorization provisions, and on or before July 1st, 2026, so at 18 months later, regarding current circumstances and the impact of the prior authorization provisions of this act on their provider members and the members' practices. To the extent practicable, the information gathered should align with national survey questions and include information regarding the impact of prior authorization processes and requirements on care delivery, quality of care, and staffing. And then it would have on or before January 15th, 2027. So again, that same date when we're asking for the insurer reports. Each provider organization that gathered information from its members in accordance with subsection A is requested to summarize and report on that information to this committee and the Senate committees, including providing a summary of the impact of the prior authorization provisions of this act on the organization's members' practices.
Questions, Leslie?
On line 21, you say align with national survey questions. Is there a national organization that creates those survey questions? Where do they come from?
It is my understanding that there are at least some. I think the American Medical Association has some. I don't know if there are others, but there was interest in some of the provider organizations in trying to align with national survey questions so that they could compare Vermont's experience with other states' experience, I believe.
So should we name those national organizations?
I'd
Or,
rather not. We typically try to avoid naming entities.
but then it's pretty vague about who's chosen. I'm just not
So
sure.
why don't we table that question, and I'm gonna look to some folks in the room who might be able to testify.
Yeah, maybe DFR can help me understand if there's a standard. I just want to know who's.
So it wouldn't
That's the
be
standard.
DFR, so,
Be the,
we're gonna answer that question in a little bit.
okay.
Yeah, and we can look at changing that language. I think national survey questions is maybe a little vague. And we could say survey organization or survey questions, published by national provider organizations or nationally recognized provider organizations or something like that.
A little more,
Yep,
yeah,
that's fair.
professional, yeah, thank you.
And I do want to note, I sent a version of this language out late yesterday to some of the stakeholders who I'd been asked to work with. They turned it around very quickly and got back to me, and I made these changes this morning, but it was very
Early.
helpful. So, yeah, so thank you, that's all. I want to say.
More to the point.
Yeah.
All right, so.
Any other questions besides that one on this language? So if we add this in, we would be getting reports from the payers and reports from the providers as to the effects of this.
We get a report from both.
Yes.
Payers. I had a question on that.
Yeah, so the previous
Go ahead.
question is the insurers reporting on the impact.
Got it.
And then this is adding
Wonderful.
section 8 to hear the.
I really
providers.
like this. I like that, having those reports.
Yeah, I mean, I think it's necessary that we hear from all sides.
Great. And then the only other change is just in the effective date to add this report. So in the provisions that take effect on passage, it just reflected the change in the name for the insurer impact reports and then added the provider impact reports so that we have these taking effect on passage.
Any questions? Jen? Okay, so. This came out early. We have Jordan on to testify. Jordan, I just want to check in. Do you want some time to look at this?
No, I think
Okay,
I can see no issues, I think, with these changes that have been discussed this morning. I think we have significant concerns with section 3 which I'm happy to share. So long story short, I don't think the changes impact anything I was planning to share this morning.
Okay, great. So why don't we, Jen, are you good if we switch to Jordan and then we'll come back to, will you be able to work on the pharmacy language here, or do you want just? Okay, I'll just keep it. Okay. All right, Jordan, if you can introduce yourself and then.
Gladly. Sure. Good morning. For the record, Jordan Esty, Senior Director of Government Affairs with MVP Healthcare. Thank you for the opportunity to comment on H766 again. MVP continues to have significant concerns with Section 3, which would align commercial health insurance prior authorization standards with those of Vermont Medicaid. The administrative work and the cost to compliance are significant and will require a dedicated project team combing over thousands of codes and crafting all new policies and IT configurations. Further, I think there will be a significant impact on underlying medical costs because this would remove a critical tool that we have in helping to drive utilization of low-cost, high-quality care and services. So as I previously shared, MVP does not impose prior authorization on any item or service unless there is a minimum of a 5-to-1 return on investment. So that means for every dollar that MVP spends on a prior auth program, there's a cost of avoidance of $5, and this ratio captures the cost of alternative treatments as well. You know, I really appreciate the comments this morning about adverse outcomes. Just want to reiterate that we certainly don't want that scenario either for our members or patients, but the outcomes concerns go both ways. So prior authorization is a critical tool, not only in ensuring kind of cost effectiveness, but also in driving utilization of known, safe, and effective treatments at a population health level. So, you know, I would also add, I think the data shows that members are accessing care, and we see prior auth as a gate, not a wall. Vermont Medicaid pays different prices, sometimes dramatically, and covers a different patient population. And we're all aware of the cost shift issues between Medicaid and commercial insurance because of inadequate Medicaid reimbursement. You know, I would raise the concern that this could exacerbate that cost shift challenge. You know, we're concerned the change will add millions in costs to our member premiums, in our view, would provide limited or no corresponding benefit to consumers and patients. It will make QHP coverage even more expensive, and we would be concerned about driving more employers out of the state regulated markets in search of more affordable options. And I also want to flag that a 2025 effective date under any scenario is going to be a significant challenge, given both the administrative lift I've mentioned this morning, but also the significant impact on prices and us having to understand how utilization patterns and overall costs might change. So we're building our 2025 products today and our pricing right now with submissions due in 2 months. So we empathize with the administrative burdens experienced by our provider peers, and we're committed to continual improvement and continued efforts and opportunities to reduce that burden. And we've had great discussions around the rest of the bill, and thank you again for those efforts and those opportunities to raise concerns and really, in our view, make a number of improvements to other sections. So MVP supports or is largely comfortable with other sections of the bill. You know, we do remain concerned with changes to Section B that narrow the permissible claims edit standard sources, but I'd say we're more comfortable with Section 2 today than we were when the bill was first introduced. You know, that said, I'd also flag that the cost and the time needed to implement these changes will be significant. And given where we are today in 2025 product development, this will be a challenge. But we're supportive of greater transparency and disclosure of claims edit standards changes and practices. We comply with the step therapy protocol requirements today because of the similar requirement that we follow in New York. We've been following that with our Vermont Medicaid business, or excuse me, our Vermont business as well. And we're certainly supportive of faster turnaround times for urgent prior auth requests. So, you know, that is kind of captures where MVP is on the bill today. Again, kind of thank you for the ongoing conversations. We do have significant concerns with Section 3, and we would urge the committee to consider removing that in lieu of a longer term conversation about what the potential impacts might be so that we're all on the same page. Thank you.
Great, thanks, Jordan. And I appreciate you coming in again this morning. Questions, Pepper and then Alyssa?
Thanks for your testimony. I have one question. We've known for a long time that this administrative burden has been going on in the providers' offices. Is there any reason why something hasn't been done sooner. You talk about improving the turnaround time. If we've known about this for so long, and the effort was to help providers with this turnaround time, why haven't we done anything about it up to now?
Yeah, it's a great question. And I would say that MVP has been working on this for some time. So since 2017, we've made a committed and conscious effort to really review our prior authorization standards to understand where, there's friction, unnecessary costs, and where the return on investment is not there. So as part of that kind of practice or that, that project, for lack of a better term, we removed, I think, between 40 and 50% of the services that we have, we had required prior authorization on at a previous point for all of the reasons that you've mentioned. We understand the administrative burden on the provider partners. We're looking to minimize that, but we do have a responsibility to our members as well to ensure that we are, ensuring safe, effective, and known care at the best price, right? So I would say in MVP's experience, we've been sensitive to that. We've been hearing from our provider partners and really working to find ways to alleviate that administrative pressure as it relates to MVP members, but it's, a larger health system with other payers. I can't speak on behalf of other payers.
Okay, thank you.
Melissa?
Wait, can I ask, was it 40 to 50% or 40 to 50 prior auths that you mentioned? Was it
So of the list, let's say 2017, of all of the prior authorization programs in place, we had removed, I think, 40, between 40 and 50% of that list. So that's an MVP specific list. So, the easiest way to frame this is, we've made a conscious effort to significantly reduce the items and services for which we're requiring prior authorization for all of the same reasons the committee is interested in this topic.
Thank you, Val. Yeah, I just wanted to get the number right here.
I wanted to clarify one thing that I think you said, but I'm not sure if I heard it correctly. So it's really not a question as much as it's a clarification. You were talking about return on investment and your 5-to-1 return on investment. Did you say that included calculations of services, other treatments?
Yes.
Okay. Okay, I thought that I heard that. And as we know, regarding step therapy, this language in this bill is almost word for word from New York State. And I believe they've had this, and you are primarily a New York-based.
Yeah, since
company.
Since 2017, I think, is when those
Yeah.
changes took
So
effect.
has MVP done an analysis of if it has cost them?
Yeah, I
anything?
went back and had some conversations with our actuarial team, and we don't have that level of detail dating back 8 years. I would say that we're following those New York standards in Vermont today, so we don't have significant concerns about costs of this change for MVP's members. I mean, at the end of the day, we largely view it as ensuring that a clear exceptions process is in place for members to access treatment, for providers to request exceptions. And again, we're not, we don't utilize these protocols to prevent access to services and treatments. We want to ensure that people are accessing those services and treatments. And, I think the protocol largely is driving that.
Thank you.
Great, thank you. Art?
Yeah, I'm listening to all sides on this bill, and I think we need to do something here. But from my personal standpoint, I want to see the payers be able to buy into something, okay? And so what I want to ask you is there language in section 3 that can be massaged maybe, and together we can come to something so that something can be done. You can be relatively happy and we can be relatively happy. Is there something there that can be worked on?
I would say, I think there's definitely conversations around prior authorization, potential reforms, opportunity to reduce the administrative burden. I think aligning with Vermont Medicaid is a is a significant challenge that I'm not sure there's there's an approach there that we would be comfortable with, primarily for, the reason that those standards are, Vermont Medicaid's employed, it puts those standards in place for that population based on the, the rates they pay for services with different utilization patterns and things of that nature. The cost shift issue is real. We know that, right? So, I think if you're asking commercial health insurance plans to align with Vermont Medicaid without recognizing the very distinct nature of the two programs and the prices that are paid, you're opening the door for even higher costs in commercial than exists today because of the cost shift, but also, we lose a critical ability to, use prior authorization, for the benefit of our members. That's just a significant tool that we have to use, and we have to use in the right way, and we have to be thoughtful about, the administrative burdens as we're talking about. But, completely removing that authority and requiring commercial plans to tie to Medicaid, I think, as we see here today, I'm not sure there's a solution there that we could support.
Okay, thank you.
Alyssa and then Leslie.
Is there language that you would be willing to suggest regarding prior authorizations? That, I mean, there are exceptions in here. Are there additional edits that MVP would like to suggest that would ensure that, some of your more high dollar, maybe experimental procedures? Is there language that could get you, I just want to say, a little happier without getting to the granular level of codes? I'm thinking about categories.
And we're talking in the context of prior auth, or
talking in prior auth.
Yeah, I did see a copy of the memo that Blue Cross Blue Shield submitted, and I think definitely the categories they outline would be something we would want to consider as well. Imaging. So really, where we're using prior auth for the most is imaging, DME, surgical procedures, and prescription drugs. So this section doesn't apply to prescription drugs. So I think those prior auth issues are off the table. And that leaves the big categories of imaging, DME, and surgical procedures. Happy to have that conversation and give it some further thought.
Which, when you look at those broad categories, eliminating or carving those out as exceptions pretty much carves out the entire bill.
Yeah.
Is there, are there any deal breakers in those categories?
Let me give it some further thought. I don't want to give you a misrepresentation this morning.
Okay.
Leslie in the top row.
I was looking at the language in C1, which says to the greatest extent possible. And I'm just wondering sort of what that means, and does that give some kind of leeway to compare, understand, learn?
I'm sorry, what page and where are you?
Page 10.
This is a question for us or Jordan? Because you're looking at us, so I wasn't sure.
I'm looking at you or the room. I don't really know what that language.
Okay,
is. I'm
so
trying to
sorry, let's
understand
start
that.
over.
Okay, starting over. Page 10, line 13, in section 3. No, excuse me, line 14, to the greatest extent possible.
Right.
So what does that mean really maybe some is, some isn't. I mean, we're just starting out. So does it set a floor for people to come back and say, okay, we tried this extent, whatever. I'm just wondering what that language.
This is just legislative intent.
Right, that we would like everyone to align with
To the greatest extent
the
possible.
greatest extent possible. Yes.
Right, so
Right.
that's the possible, I'm just wondering if that's a door. So maybe not, maybe since it's just an intent and it's
I
separate.
mean, it doesn't, it's just intent. The language itself that we have in here is still asking them to align with Medicaid.
Yeah.
Where
And
is
our
that?
intent-
Where is that language?
To align-
Where-
Page 10,
line 13.
The greatest extent or the language I just said?
Language you just said. I saw the greatest extent, but
So, starting on row 16, a health plan shall not impose any prior authorization requirement for any admission, item, service, treatment, or procedure that is more restrictive than the prior authorization requirements that Department of Vermont Health Access would apply for the same admission, item, service, treatment, or procedure.
okay, just wanted to locate that.
Yeah. So what we're basically saying, Leslie, is our intent is that we really need people to start aligning so that a provider isn't always putting in a prior authorization for every single thing, because they're just not sure which payer is asking for
And
what.
that's what they were doing.
Right,
Yeah,
and so, but the bill itself says that, the section 2 is really what we're asking them to do.
yeah.
That help? Yeah. Okay. Any other questions? Oh, Tucker.
Yeah, thanks for for removing 40 to 50% of the services that needed prior authorization. So that led me to another question. Of the ones that are left, that are required prior authorization, what percentage of those, on appeal, or if they didn't need an appeal, what percentage of those were actually granted?
Yeah, I'd have to go back.
Uh,
I can confirm this and follow up, Representative Topper, but I think the DFR had highlighted these numbers when they spoke a few weeks ago. I think at the end of the day, we've got roughly a 3% denial rate. And those denials were, I think, largely upheld on appeal, meaning that those are appropriate denials. So we look at those
So
data.
97%,
Yes,
those that needed prior authorization.
yes, are approved.
Leslie?
Just so I understand, and this is for you, Jordan, thank you. How does this requirement in 2 compare to what you do in New York? Is there any connection with what you do in New York?
No connection whatsoever. So we manage our own prior authorization standards across our commercial book of business. So, we don't have a different set of standards for Vermont than we do for New York, unless there's some state-specific requirement around a particular item or services, then that would be reflected in our Vermont commercial business. But we do not follow Medicaid standards in New York, though we certainly consider them.
Great. Any other questions for Jordan? All right, Jordan, if you have any suggestions, we are looking for them this morning. So just let Claire know and we can have you back on or stay on if you're able to.
I appreciate you.
Yeah, thank you, Jordan. We appreciate your time too. So our legislative council had to run to another committee. So she'll be back to walk us through those couple changes we wanted.
Sorry, agitating here. Jordan, could I ask you another question?
Yes.
Thank you, I'm sorry. Do you have any sense of what the overlap is from your PAs from New York Medicaid to yours? Is there any connection there percentage wise?
I'm sorry, I'm confused. I can't see who's asking the question.
Oh, Leslie Goldman here.
Oh, Representative Goldman. Can you repeat that again?
I'm just curious if you have any sense of what the overlap is from the PAs from New York Medicaid to yours, if there's an overlap.
I'd have to look. I imagine there is, because New York is a Medicaid, it's a managed care state, so they contract with
Yeah.
MVP to run
Okay.
their program, but they certainly have a view on what they want incorporated in a prior auth, but we do have some flexibility there because that's part of the engagement. We're, achieving better quality and outcomes on behalf of the state. So they've given us some latitude in Medicaid here to utilize some of the standards we have in place for commercial, if that makes sense.
Thank you.
But there's going to be variances because we're talking about different populations.
I understand.
Okay. So, we need to hear back from Jen. We're going to have a committee discussion, but before we start that, is there anyone in the room who would like to testify? At this point, are you good with your question on the national standards if we change it slightly, or did you want to say anything? I don't want to put you on the spot, so if you don't want to, that's fine.
No, that's okay. Stephanie Winters from the Vermont Medical Society and other organizations. I am just as understudy here, as she flies away. So I would say nationally recognized is appropriate. I would not want to name specific organizations, but off the top of my head, I'm thinking the American Medical Association, the American Academy of Family Physicians, American Academy of Pediatrics. Like there's a number of specialty membership organizations, and the language puts that onus on the organizations in Vermont representing the group. So it would be BMS, it would be Susan from Health First, it would be Boz, Devin. So we would come up with the appropriate organizations.
Thank you very much. So does that help, Leslie?
I can't remember what page I was on.
It was circled it, so hold on. Like towards the back, page 18. And I think Jen will tighten up the language a little bit.
Yeah, I think national survey questions bother me. Surveys are hard. Surveys have to be done well to be usable. I'm not sure what I mean, I hear what you're saying. I'm not sure if it would be appropriate, such as the blah, blah, blah organization, just.
Well, I mean, I think Ledge Council's also saying that we should not name.
Yeah,
And also to the point of if the survey questions are being used in other states, it's a really good way for us to compare how our law is impacting things compared to what other states are doing. So I can send everyone what we got from Jessa, which is examples of some of the questions.
that'd be great.
So that you know, I'll send that out to everyone. Alyssa?
Yeah, I was gonna make a comment, but I'm fine. Thank
Okay.
you.
And so everyone else is
I
good
have
in that
a
gallery?
question. Maybe I've seen it and just can't recollect it. But when we talk about aligning to the greatest extent possible with prior authorization requirements of Vermont's Medicaid program, what are the requirements of the Vermont Medicaid program?
So we took testimony from Vermont Medicaid on their process, in that they have reduced prior authorizations a lot without utilization increase. So this legislation is saying payers have to get with Medicaid and align their prior authorizations where appropriate with Medicaid. Yes.
So with that, Lori, when we say to the greatest extent possible, then that gives the payers some leeway as to what they can do. Does it not? Or
Again, that is intent language, and so we are not saying you must align, we're saying to the greatest extent possible.
okay.
But the must comes next.
The must
That's what,
comes next into,
Okay, all right, got it.
where it's
Yeah, yeah.
not,
That's-
the language is,
Starting.
sorry,
Yeah.
not, would apply, or shows that is more restrictive than the prior authorization requirements. And if Medicaid does not have a service that the payers do, then the payers would do what they want because Medicaid does not have that service.
In the committee discussion phase of things.
I think so, because I haven't seen anyone raise their hand about wanting to testify.
Yeah.
So let's have a committee discussion.
Well, I'm in a dilemma with this bill. I like the bill. I think it's good. The theory of it is great. We've all sat here. I don't know beans about healthcare yet, really, but
Yes, you're
well,
learning.
I really don't.
more
I really
than-
don't. I don't know. I can't put myself in that doctor or that clerical person's place and see the frustration they must feel. It's very real, obviously, because it's a problem. And I think the theory is good, but if this truly causes premiums to rise because it is so onerous for the payer, I get very nervous about that. And for me, I'm trying to see if we can strike a balance
Yep.
here a little with, that's why I asked Jordan that question, and we'll probably ask Blue Cross Blue Shield the same one. And somehow get to a spot where we get something and we don't see a rise, because I truly believe the Vermont taxpayer is tapped out. And we have to be very careful what we do. Just my 2 cents, Lori.
I agree with that. That we have to be careful of what we do. Topper?
When I asked the question about, what have you done about
Yeah,
reducing it? The answer was 40 to 50%
Right.
have been removed.
right.
Okay, then I said, of the remaining, how many denials did you have? That was 3%. So essentially, 97% of those prior authorizations are approved. So I have a tough time trying to figure out how that's going to increase the premiums.
And I totally agree. I gotta hear a lot more about that.
Because if
Totally
they're
agree.
approving everything, why are we putting
I
providers through the process?
know, that's what I don't know. I don't know. I don't get it, frankly.
So I want to level set the conversation as we go forward. So this is a hard bill. I agree with you, Art. I was up most of the night last night thinking about this bill, quite honestly. And it's hard because normally we do like to have agreement. I mean, we work really hard in our committees, not just this one, to have agreement on legislation. And I was thinking this morning on the drive down of the drug repository bill we did and how that was great. It was like this feel good, everyone agreed. And we should have put in our budget letter that we really want to make sure that happens, and we didn't. So, but so this is hard. And this is something we have tried to tackle for years.
Yeah.
And the reason we can't is this tug of war between what might happen with premiums and what might happen with providers. And there's no clear cut answer on this one.
Yeah.
So we're going to add the piece about pharmacy, which does knock down the cost that we heard, specific to that piece of it. And I think it's going to be a conversation we have, a respectful conversation, but understanding that this is one that we just can't make everyone happy. And at the same time, I agree with you, right? Like we need to think about the patient who's paying the premium. But we really don't have,
You have nothing to go by,
right? We don't have anything to go by at this point. And if we talk to patients, that also is a mix because I've talked to people and some are like, oh, no, don't do anything to raise my premiums. And some are like, I will pay more if it means that I'm going to have more access or that I'm not going to have to worry about the prior auth with everything I need. So across the board, this is, a hard one. So with that, I'll open it up. Daisy and then Alyssa.
Premiums are going to rise no matter what, and we don't know how much. We do know how much they've risen in recent years, and I agree, it's killing us. And so many of us are underinsured or uninsured, and I just want to lift that point up. Is it?
So I just wanted to, a couple thoughts. I want to reset and remember how the bill started. And we worked very collaboratively, I think, with all the organizations. From the get-go, we got rid of prior approvals for prescription drugs. So, that was, I want people to remember that was still in there. And we heard Jordan today. We've had pushback on the step therapy people. And we heard Jordan today, MVP has been doing this in New York State, because this is New York State language since 2017. And they haven't they haven't even bothered to measure it. Not to go all ways and means, but apparently it's been de minimis.
Still can't.
And I mean, personally, I could, and you were in working group as well, is very open to suggestions around, I mean, there's a recognition that, to Topper's point, there are some things that really, really should have some prior approval. I mean, you just can't have carte blanche everything. And I recognize the insurer's interest, the payer's interest. I mean, there are high dollar procedures and, you know, but fundamentally, these things are these are tiny little pieces of the whole of what they're requiring. And like I said, I mean, I'm totally open if aligning to Medicaid is not doable, then make some suggestions,
Which we've asked
which we've asked.
since we introduced.
Yeah, I mean, that's as open as we can be, I guess.
Yeah, and just coming back with, well, we think you should add this language, and it literally lists every single procedure that they require prior approval on. That's.
You done? Melanie?
That was what I was hoping we would get, like what are the absolute essentials that are needed could be prior auth and non-prior, well, but, and then when I read some of the memos that came in and it was just everything, I was disappointed because I feel like we need to do something. We're asking for partnerships and, I still feel like we don't have those things from our partners. I'm sad by that. I wish that we need to do what's best for Vermonters, both the patients and the providers, and make a sustainable model. I look at our guiding principles and I wish that the list had been just not exhaustive of every single thing that everyone's prior out. It's like the things we need to carve out. It didn't seem helpful in the memo. So I don't know if there's a way to get to what you just spoke of, Alyssa. Because I would be interested in hearing what are those 3% that were denied that Copper and I were like the percentage, like what were those 3? What were the ones that were absolutely essential? And can we get incrementally there? That
would be at least a start.
Start, yeah.
I do want to put one thing on the table, which I forgot. I apologize. I had a conversation with Diva yesterday and they were supposed to, send written testimony and they have not yet. But section 6, which is, if you remember the original bill was, quite broad and requiring, what I'm going to call direct billing, but insurance companies to be able to collect all of the billing. We heard loud and clear that is not feasible. And so we put in a working group. We've heard from Diva that they would need resources in order to do this. And they also don't necessarily think they are the proper entity to do it. And so while I think our intention is it would be great if we could do this, I'm asking that we strike it from this bill. Section 6. And, you know, someone can come back to it next year if it's. But we heard loud and clear it would take a lot of effort to get to this point. And Diva isn't willing to do it. Any
Can you
concerns
say again
with
what the
that?
working group would do?
So this is the section where, well, I can tell you, it says, consider ways in which health benefit plan designs and methods of collecting patient cost sharing may be developed in a manner that reduces the administrative burdens on patients, healthcare providers, and payers, including a consideration of payers billing patients directly for the cost sharing amount. So this, the idea was you go to the doctor, you pay your copay, and then later on you get a bill from the insurance company. The idea was, can that copay be part of that collection from the insurance company? And then, providers get paid and it was, I will say, when we put it into the bill originally, it was kind of like this, oh, well, maybe let's talk about it and there might be some potential solution, but I think it's pretty clear that there's no solution on that right now. So I'd like to take it off the table.
Yeah, I agree.
Okay.
To strike out
strike out the whole thing.
Section 6.
Yeah. Bobby?
Just an idea that popped into my head as we were talking about the percentage that the 97% that get approved at ultimately. If maybe the payers could provide us with a list of procedures that get denied more than 50% of the time, so kind of an objective number. And then those could be allowed to stay on the prior authorization list, things that most of the time don't get approved. I don't know if that's even possible for them to sort out. It seems like an ask of something that would be an objective number. It wouldn't be subjective to any, and then we could, that's just a request. I don't even know if that's possible. Because there may be some procedures that are most likely to get not denied, and those could remain as required prior authorizations. But things that are most of the time approved would be removed. I don't know if it's too simple to think that way, but I don't know, just an idea.
So we'll put it on the table if anyone wants to come back to us later this morning. Art?
One of the things with this that frustrates me and all of us, I think, in the room probably is the time it takes to do this stuff. And I'm trying to, you would know most, Alyssa, I guess.
But we also have providers in the room, so
Okay.
I want to make sure Alyssa isn't the only one.
Yeah, no.
Provider witness. and she's
And,
not a provider.
right, no, actually, they know more.
Yeah.
I go in for something. The provider suggests I have a procedure. Why does it take more than 5 minutes to get that approved? If my provider, and she does, it's got a computer, why can't that immediately go to the insurance company and the insurance company immediately make a decision and you're done? I'm not getting the wrangle, I guess. I don't understand that. Because it seems to me that would be an easy thing to fix.
Kelly, are you listening? Or,
I am, yep.
so can you walk us through from a provider what happens?
So I can go at a very high level, but I am not the operations person.
Yeah.
I can say in part of that, so some payers have different forms. They may have portals. They may use vendors. So there's certain payers, for example, sorry, I see your hands in your head in your hands. I'll just say, we have two payers that use a vendor, especially for oncology services. We have to, and that one vendor actually has two different processes. Even though they're the same vendor for two different payers, they have a different process for each payer. So we'll submit online to a portal, as you're saying, the staff, a prior authorization staff, and then it gets reviewed either by the vendor or the payer. And they may ask for different additional medical records. You would put in the code, what you're looking prior authorization for, the diagnosis and why, which is pretty standard. I will say on the pharmacy side, and Jordan can correct me, but this is where there is more streamlined work, representative, in terms of really more access, and Jordan, you and I are the high level on this, but there are more online tools for that, as you're describing on the pharmacy side, I think, because that has become a little more standard in a sense. But I will say, in terms of radiology, oncology, surgical, payers simply have different standards. So we can't submit in that manner. It's not a clearinghouse, for a lack of a better word, does not exist.
Thanks, Kelly. Jordan?
Yeah, I would just add to that. Definitely a lot happening in the pharmacy space around automation, but I would also point to the federal government and some efforts that are happening there in the Medicare program in particular, where there's a set of new regulations that were just finalized, where the policy objective is to drive as much of prior authorization to automation as possible, and we strongly support that. I think that's the end game there, is to reduce the friction on all sides while preserving the kind of the importance of prior authorization. So automation is the North Star. I think there's a lot of challenges to get there, but that's definitely where we'd all like to see it go.
And I'll just add, if you don't mind, I think in terms of the automation, that's why we're working on alignment. If we have aligned processes or requirements, we can get to automation. And so that's really, from our opinion, where it started. But you are right, Representative, it's not just, like you're going on Amazon and you put in something and you get a response that you order. Unfortunately, we are
Seems like
the,
it's easy.
We
Sorry,
are-
Kelly, go ahead.
we are working with payers though, in terms of our electronic medical record systems or health record systems to connect and use that in a more efficient way. That of course comes with a cost and time, but we are looking at those avenues as we approach this alignment focus.
Thanks, Kelly and Jordan.
Can I follow up with that? For patients that are relatively healthy, you go in for a physical, you've got to have a little bit of this and a little bit of that, but not high level, high cost things. How long does prior authorization take for those things? Not the oncology, I don't know, whatever, small things. Does every visit require prior authorization? I
I'll
don't
speak
know.
and then I can have Susan from the Independents if you have it. No, by no means does your preventive visit, your primary care visit, and a lot of preventive services no longer require prior authorization, which has been to what I know Jordan testified to. So some payers have made a reduction in that. So that is not required, but we are talking about perhaps after you go to your preventive visit and you've got your back is really debilitating, you're not feeling well, you want to go for an MRI. It's that follow-up, and that's where some payers are quite quick in responses. That's more standard, but some payers have different protocol on that MRI requirement. So your preventive visit does not generally require or general labs at the high level does not require the authorization, but a lot of follow-up services do.
Thank you.
Jordan?
Yeah, I just want to add real quickly around the 97% number, because that's been referenced a few times here. So I pulled up the DFR report, and that is a member impact denials number. I'll circulate the information for the committee, but there's a lot more detail around prior auth utilization review and appeals that I think gives some of the granularity to demonstrate where there's higher levels of denial by services than others. So I just wanted to clarify that 3% so that we don't get fixated on that as an incorrect benchmark.
Thank you for that clarification. All right.
Are we still having discussion, or are we gonna pause?
We can still have discussion, and then we're gonna take a little break. I'm gonna check in with Jen, and then we'll come back to the table. So what else? Brian, and then Leslie.
So I was listening since the meeting started this morning and thinking about this. And I feel like, I don't know who said it. So someone was talking about how, maybe it was the chair saying how like we try to like build consensus and like have everyone win. And then every now and then there's a situation where we have to like decide who wins and who loses. And I feel like in the 8 years I've been here, too many times providers and patients lose. And if in this decision, the payers lose and the providers and patients win, I'm okay with that. And I feel like every time we start to go down that road, the same thing happens where I feel like I maybe threatened is too strong of a word, but there's like this threat or this risk that's raised of like,
Risk.
yeah. So I'm trying to use like softer language and be sensitive to people's feelings, but it's not about people. This is about institutions and structures. Yeah. So that there's this like risk, this like fear that is invoked in us of like, if you touch things, it's going to make it worse. But like, then it keeps getting worse. And this is what stopped Vermont from going down the road of universal health care, and that premium costs were going to be like skyrocketing. And I think if you compare the projections to now, I think they're actually worse. So I don't feel bad letting the patients and providers win today. But I don't think it's over there, because it's going to have like ripples. And so I can guarantee that we're going to hear like premiums are going to have to go up. This is going to have to happen. but that keeps happening anyway. So what I'm hoping is that after this decision, that we can, that maybe it'll force us as a society to look even more closely at the cost. I think it was the first witness who was talking about what I would call the true cost of the decision, because it's like all these additional things that don't get factored in. We really need to like account for the true cost more of the healthcare system and take those things into account, because it's not just about the premiums and deductibles or what the providers are getting paid. It's the quality of life of people. It's impacting all these other systems that we spend money on. And it is really complicated and hard to figure out. And hopefully, regardless of who wins and loses today, like we can lick our wounds and come back and like continue, because that's what patients have to do all the time. And that's what providers have to do all the time. And
that's our job.
yeah. And so hopefully if stakeholders involved on the payer side feel harmed, I'm sorry, but let's just keep trying to make it better for everyone. And I'll just stop there.
Thanks, Brian. Leslie?
Yeah, thank you, Brian. I think that says it well. I'm still struggling with this. I get that there's a totally different payer mix between Medicaid and commercials, and that seems to be a concern. That's what I've heard. Is there another benchmark that we could use other than that has a more consistent payer mix with them? I'm just trying to think through how to address that disconnect.
So I'm gonna put on the table that this is not the first time we're seeing this bill. We've talked to the payers, we've asked for input. This is what we have on the table. There's Medicaid, there's Medicare, there's insurers, commercial insurers. That's who we have. So.
Another state, I'm just trying to sort of,
Get
through the muck. I mean, it feels very mucky, yeah.
It is very mucky. It's been very mucky for, years. I mean, I think we saw some things that we've discussed claims edits back as far as 2011. Kelly?
Thank you. I want to just address the different from Medicaid population. And I know when I started in healthcare many, many years ago, that perhaps might have been more true. But as in this state, as we've had expanded Medicaid, the Medicaid population goes through the exchange, can transition hopefully through additional workforce efforts, perhaps if it's not a disability-based Medicaid. But Medicaid has all ages, all different populations, has employed people, it's unemployed. It's really not simply what previously would have been. Medicaid is a very small subset of a population that's different, especially in this state with expanded Medicaid. So I just wanted to say that categorization of the Medicaid population, I don't think no longer is true. They're Vermonters, they're a cross-section of Vermonters, much like our commercial payers.
Thanks, Kelly. Okay, I'm gonna suggest we take a break, let Jen have a breath and do her changes. We'll come back at 11, walk through the changes. Is that, oh no.
Sorry, I just committed to appropriation.
Okay, so we're not gonna take a break. We're gonna take a break for 5 minutes.